includes infertility management, IVF, ICSI, IUI, vitrification, operative laparoscopy, hysteroscopy, high-risk pregnancy management, adolescent health. So, I welcome Dr. Sonam. Thanks for joining us. Let's begin. Now I hand over the stage to you. Yes, ma'am.
Good morning, everybody. I first of all thank the Subhag team for giving me this opportunity to share my views on optimizing the IUI outcome. As we all know, infertility is increasing day by day. Next. So what is subfertility? There's no word as infertility now. It is called as subfertility. And what is the role of IUI? Subfertility definition. Medically, a couple is often classified as subfertile if they have not achieved pregnancy. If the age is less than 35 years, then for 12 months after regular unprotected sexual intercourse, and if the age is more than or equal to 35, after 6 months, the patient is categorized as subfertile. So why talk so much about IUI? IUI is the first line of treatment in subfertility because it's simple, effective, and inexpensive, and can be performed by all the gynecists, even in remote areas. Next. Next. So let's talk about the success rates and benchmarks. Total motile sperm count and the cycle impact on the IUI. Total motile sperm count thresholds like less than 5 million, the IUI success rate is low. If it is less than 1 million, it is very low. And number of cycles per cycle, the result 10 to 15%. And after 5 to 6 cycles, it is 60% cumulative. That is as equal to as one ICSI cycle. IUI husband, if the age is less than 40%, pregnancy rate is 12.5% per procedure. If age is more than 40 years, it is 7.49%. IUI donor less than 40 years, pregnancy rate is 18% per insemination, and 40 plus years, it's 9.2%. So similar is with chance of pregnancy. We all need to know what are the chances of pregnancy when we counsel the patient for IUI. So if the patient does intercourse on own, the chances of pregnancy is 2%. Intercourse on own, 5 to 10%. If the motile count, then the success rate is 25%. Intercourse on own, 10 to 20%, 10 to 20 million count, 0.4% only. And stimulated cycles, IUI, stimulated counts more than 20 million. The chances of getting pregnant are 10% with IUI. Next. So what are the factors affecting IUI outcome? I hope everybody knows what is IUI. It is intrauterine insemination of the sperm which has been collected, clarified, and concentrated by various methods. So various factors which affect the IUI are key factors are semen parameters, age of the women, ovarian reserve, etiology and subfertility, superovulation versus natural, or timing and technique, number of inseminations, number of cycles, luteal support. Let's come to the factors. Male factor, the incidence of subfertility incidence is 30 to 50%. 30% severe male factor. Now, efficacy of 6 consecutive IUI cycles is comparable to 1 ICSI cycle. Therefore, IUI is not a single treatment, but series of successive trials. We need to counsel the patient accordingly so that the patient stays with you for a longer time. IUI is not a single treatment, but a series of successive trials. Proper patient counseling assures long-term retention and trust. Next. So how do we do the insemination and sample collection? Let's talk about first the factors affecting the pregnancy rate. Insemination parameters are semen collection, fresh versus cryopreserved, semen processing technique, motile sperm count, volume of insemination. So lab collection, just hold on for a minute. So home collection, if it is done, it should be within 30 minutes. Do not refrigerate, protected from sunlight, sterile container from the lab should be corrected. Consent of both partners is compulsory for home collection. So when you get the sample, the patient should be instructed to keep the sample in the pocket or in the axillary area and get it within 30 minutes. So when it comes to lab collection, the standards at the you should have a privacy for the patient, clean and proper and total collection. No lubricant has to be used, no spillage. If yes, specify part first, last, or general, and provide sterile, pre-labeled, sealed container to the patient. So next, now what are the lab aspects which affect the result? It's the quality, the sterile laminar flow, proper lab cleaning, technician expertise, because many human errors, judgment of collected sample, and faulty techniques lead to poor results. So what can be the semen preparation techniques? It will depend upon which method of sperm preparation will depend upon whether the patient is normospermia or it is oligospermia. Normospermia, the viscous and pellet swim up. Non-viscous, directly overlay. In oligospermia, if the total motile sperm count, TMSC, is less than 3, then the pellet swim up, or TMSC is more than 3, then gradient configuration has to be used. Now, which female factors affect IUI success rate? 850 cycles of 350 couples were studied. Live birth showed strong negative correlation with female age, but no correlation with male age. AMH and AFC correlated negatively with female age, and FSH correlated positively. Calculating miscarriages showed a strong correlation with increasing female age. Male age had no effect on rate of pregnancy loss. So it is very important that we pay attention to the maternal age. Now, what can be the etiology of next? So all of you must be aware of etiology and cycle strategy, because etiology of subfertility can be unexplained infertility, pelvic adhesions, severe male infertility. It could be either, the etiology of subfertility will decide whether we have good results or poor results. If you have unexplained infertility, cervical factor infertility, anovulatory infertility, or donor IUI, the results are good. If it is severe male infertility, tubal factor, pelvic adhesions, or severe endometriosis, then the results would be poor. We need to understand when we expect good results and when we expect poor results. So who are good responders? Next is natural cycle versus combined ovarian hyperstimulation. So natural cycle, the pregnancy rate is 11.35%, and COH group is controlled ovarian hyperstimulation from on, I will say, COH. 19.6%. The ovulation induction cycle could achieve a higher pregnancy rate than natural cycle in IUI, particularly for infertile patients under 35 years. Next. So, previous one. So patient profile comparison will depend. A good count of pre-ovulatory follicles, good ET, good PMS count will help us have a good result. If it is an older self plus partner, longer duration of infertility, poor ovarian reserve, poor ET, poor sperm quality will have poorer results. Next. Next. So what is the critical window? Timing is very important. I would just like to add some points on natural IUI can be done in unexplained infertility. So do we need to have all IUI cycles to be stimulated one? The pregnancy rate was lower in natural cycle as we have seen. It was higher in stimulated ones. There was no difference in pregnancy rate among the subgroups of clomiphene citrate, HMG and clomiphene citrate or clomiphene citrate plus HMG. So natural cycle is usually offered to those patients who have donor inseminations, mild moderate male factor infertility, cervical factor infertility, or especially if the female age is less than 30. So when is the timing of the IUI? The timing of the IUI is very critical. Survival of germ cells within the body. We need to know this very clearly. Sperms, it is 3 to 5 days, and ovum is only for 24 hours. Timing is more important for IUI than it is for intercourse. The reason is that during intercourse, sperm travels through the cervical canal. There are glands and mucus in the cervix that sustains the sperms and acts as a reservoir that releases sperm into the uterus slowly over several days. Timing during an intrauterine insemination, the sperm are released into the uterus. The sperm do not remain viable for as long a period of time. Consequently, the sperm must be inseminated close to the time of ovulation. So one method to time an IUI is with an ovulation prediction kit. The kit measures women's LH surge. The surge peaks about 12 to 24 hours before the egg is released. A woman will test her urine in the morning. If the test is positive, she would have the intrauterine IUI the next day. Another method for timing of IUI is artificial trigger insemination, IUI 34 to 36 hours after HCG injection. So research inside pregnancy rates are the same if IUI is done after short 32 to 34 hours interval or long 38 to 40 hour interval after HCG. So after 36 hours of HCG or after documented ovulation or along with HCG. Next. So when should the IUI be done? After 36 hours, after ovulation is documented, or along with HCG? Or should we wait for the follicle to rupture? So postponing IUI until observation of follicle rupture may yield a higher pregnancy rate. These studies show this because if rupture is evident, chances of pregnancy is 23 to 5%. Rupture not evident, 8.8%. So timing, we have to fix the timing protocols. They can be either fixed protocols or variable protocols. So fixed protocol, single IUI is done 36 to 40 hours post HCG, double within 12 to 48 hours post HCG, or variable TVS 36 hours post HCG ovulated single IUI, TVS 36 post HCG, not ovulated, IUI at once. Since single versus double IUI, meta-analysis of randomized trials show that no difference regarding the pregnancy rate between single 24 hours or double 12 and 36 hours inseminations. Next. So what is the role of abstinence before IUI? It is not necessary to abstain from intercourse before doing an IUI. Sperm counts vary in all men. The frequency of ejaculation does not have any consistent effect on sperm numbers. Sometimes there will be more sperm on a second or third ejaculate, or sometimes there will be less sperm. Recommendation is to have intercourse on the day that an ovulation kit turns positive or on the day that an HCG trigger injection is given. The IUI is then timed as indicated above. So how do you get the procedure excellence? Sample at 37 degree, cross-check the identity, aseptic precautions, sterile powder-free gloves, consent, must verify Aadhaar card and marriage certificate. You can take it from the ICMR website. Most important is before doing an IUI, you need to have level 1 clinic registration with your ART body. And if you have IUI donor, the protocols are no fresh sample is to be used. Reputed semen banks have to be taken into care, not from known donor. No mixing of donor samples, and there should be presence of records. Next. So what are the clinical tips and tricks to enhance the results? The clinical tips, like we have cervical mucus aspiration gave pregnancy rate was 15% as compared to 9.9%, in which no cervical mucus aspiration was done. Ultrasound guided gave us a pregnancy rate of 23% versus 13%. It reduces difficult cases. Passive straightening, use atraumatic Alice forceps, so there is no locking, straightens angle between cervix and uterus. So what is the injection technique? Speed should be slowly inject sample over 30 to 60 seconds, finally inject column of air to push the remaining sample. If injected too fast, flushing and retrograde flow may push sperms into the peritoneal cavity. So what are the technical specifications? The catheter choice, ideal device is non-toxic, semi-rigid, easy to use. Soft versus firm catheters show no significant effect difference. 0.4 ml or greater reaches uterus. Tubes, variation in uterine capacity may affect tubal perfusion. Full bladder helps in straightening the angle and visualization if using ultrasound guidance. So what is the post procedure? Removal catheter is gently removed, taking about 60 seconds. This is very important. Patient lies flat and still for 15 minutes. No need to elevate legs. Next. So after IUI, you need to give luteal phase support. So luteal phase support, you have progesterone options like natural micronized progesterone or dihydrogesterone. See, meta-analysis results show that vaginal progesterone significantly increases live birth in gonadotrophin stimulated cycles, but not in CC cycles. So endometrial factors affect, it is the thickness and the trigger. Pregnancy rate increases with thickness on day of HCG. Delayed trigger till endometrial thickness is 7 mm. Consider adjuvants or hysteroscopy or endometrial sampling. So what is the aftercare? 10-minute bed rest has positive effect. Normal life intercourse after IUI is okay, increases total sperm count. So what are the patient instructions? Patient should be called to the hospital bag if she has abdominal pain, fever, onset of menses, or if menses is 3 to 5 days late. So we can check for the pregnancy test. So when to cancel the cycle and how to proceed? Next. We need to know when the cycle is to be cancelled. Whenever you have more than 3 follicles which are more than 17 mm, you need to cancel the cycle. So how many IUI cycles can you do? So best results will occur in first 3 to 4 attempts, and average monthly fecundity rates is 19%. So cumulative probability of conception after 6 cycles is 50 to 60%. So we've already discussed what is the predictive factors for pregnancy after IUI. The couple with the best chance of pregnancy under the age of 30 with cervical or anovulatory infertility, a man with total motile sperm count more than 10 million sperms. The ideal stimulation cycle enables the recruitment of 2 follicles measuring more than 16 mm with an E2 concentration more than 500 picogram per ml on the day of HCG. The best results are obtained when IUI is performed using a soft catheter. So IUI is a teamwork, involves the clinician, gynecologist, ultrasonologist, dedicated and trained lab staff, trained nursing staff, receptionist, and the record keeper. And what's your take-home message for all of you? Proper patient selection, appropriate stimulation protocols, good quality lab work, meticulous procedure, and luteal phase support. I hope I have helped you out with clearing your doubts. The most important thing which is required for IUI is patent fallopian tubes. So that test is the most important test which you should have before you attempt an IUI. Thank you, everybody.
Thank you, Dr.
Okay,
Sonum Sachdeva.
now, yeah.
Yes, sir.
Yeah, so I think let's let's take the questions. I think there are a few questions in the chat box. Let me read it out for you, ma'am, so that you can.
Okay, so the first question from the Suman Sarma. According to ART, we can do 6 cycles.
Can we do
Yes.
6 cycles? So that's the question, yeah.
Yeah, you can. According to ART, you can do 6 cycles.
Okay. The next question is from Dr. Supriya Sonamane. Difficult IUI, how to proceed?
In patients, when you suspect difficult IUI, first of all, on ultrasound, you'll always see some problem with the cervix and the uterine connection. One thing, if you have any kind of this, if you faced, it's always better to follow, to precede the next IUI with a hysteroscopy. And if there is any kind of cervical stenosis or there is any kind of problem that needs to be taken care of.
The next question from
Another thing is that you can have full bladder, use a soft atraumatic Alice, then that can help you to straighten the angles. And at times also we have, if we soften the uterus with something like misoprostol in a very low dose, it does help us to cervical dilatation.
Okay. The next question from Bhavya, she's a embryologist. She's asking if semen parameters such as count, motility, and morphology are within normal range, what are the most common factors contributing to IUI failure and how should they be investigated?
Even if the counts are normal, the most common factors, if the male factor is totally normal, then we look into the uterine factors, because tubal factors, endometritis, cervical mucus, then there may be immunological factors also. Because even if the counts and morphology are normal, we don't know the quality of the DNA of the patient, of sperm DNA. So we need to take care of that. We need, at times we need to have the chromosomal studies for both the partners also. They can be, that can be one of the reasons for failure of IUI.
Okay. So, don't know the name, that because their mobile name is mentioned here, Samsung. So DNA fragmentation may contain in a sperm. So this is a question or answer, I don't know.
If there is DNA fragmentation in the sperm, you need to give them supplements and find out the cause of DNA fragmentation. Then accordingly treat the patient for 2 to 3 months. Then check the sperms again, and then you go ahead with IUI.
Okay. From Dr. Sadhana. So she has question, can we do HSG and IUI in same cycle?
Yes, you can do that.
Okay. Again from Dr. Supriya, luteinized unruptured follicle, how to manage?
Luteinized unruptured follicle syndrome, it's quite common. Then you have to follow with the hormone reports. One thing, the ultrasound has to be done more frequently, so you get to have the serum progesterone levels at the beginning of the cycle also. Because if the progesterone level is high, then you do not need to stimulate the patient in that cycle.
Okay. From Dr. Priyanka, can we use raw semen sample for IUI?
No, raw semen sample can never be used for IUI, because patient will have an anaphylaxis shock because of the seminal vesicle enzymes. So it has to be always to be washed and then used. A liquefied sample only can be used. If your sample is non-liquefied, it can never be used.
Okay, the next is Samreen Salam. In which cases we do double IUI?
As the studies show, the result is equal, but double IUI is basically done in those patients in which the counts are low and the age is more. In those patients, it is an attempt to increase the results, but overall studies show the result is same.
Okay. So the next question from Dr. Sanmati. Can we do IUI if a patient has recurrent miscarriages?
Yeah, you can do IUI, but then you'll have to do with the donor consent.
Okay, again from Dr.
The cause
Supriya.
of recurrent miscarriages may not be sperm. It may be the shape of the uterus.
Okay. The next question is from Dr. Supriya again. Luteinized unruptured follicle next cycle, how to proceed?
Get your day 2 hormones done and then stimulate with HMG. Because for that, oral drugs usually cause unruptured luteinized follicle. And plus, when the size of the follicle as well as the perifollicular flow is sufficient, even if the size is small, then you can give a trigger to the patient so it ruptures. And on the day of trigger, not only will you give the trigger, plus you will also give another dose of HMG.
Okay. The next question from Dr. Sheila M. In which cases we consider DNA fragmentation index testing through normal routine semen analysis?
Usually DNA fragmentation index is done for those patients who have a failed IVF or failed IVF cycles.
Okay.
Or if we suspect that the sample is looking normal, but it is not giving us results.
Okay. I think this question already get answered. Dr. Priyanka, can we use raw semen sample? You said no. Okay. The next question from Dr. Supriya. NN fragmentation, then fluidic use.
Microfluidics is used mainly for ICSI cycles.
Okay.
For IUI, you will not get sufficient sample.
Okay. Is macrofluidics in IUI better a sperm selection method than centrifuge?
No, definitely. They say but the cost is involved more. IUI is a very inexpensive technique till it is used with centrifuge. If you use things like microfluidics, one thing is if you do not get sufficient sample, then it is forfeited. What is the indication of IUI is given up.
Okay. Dr. Sadhna has again asked cost of IUI macrofluidics.
I think minimum is around 4,000 for a single use.
Okay. From Bimal Gupta, if endometrium thickness is not up to the mark, what medication we need to use?
You have to find out the cause of less endometrial thickness. Usually it is chronic endometritis. In India, tuberculosis is very common. Hysteroscopy can be done. Then hysteroscopic various other adjuvants can be used to increase, and drugs like CC should be avoided. Or you can use along with it estrabet gel or estrogen gel can be used to increase the thickness of the endometrium.
Okay. The next question from Dr. Saumitagya Vanu. If progesterone on day 3 is high, how to reduce it, ma'am?
Give OC pills for 2 cycles.
Okay. Again, it seems Dr. Sadhna, what to do if follicle is 18 to 20 mm, but it is thin, less than 6 to 7 mm?
Endometrium is thin. Give estrogel gel.
Okay. The next question in, from Bhavya, CJ embryologist. What will happen if insemination takes time than a prepared a sample time more than 25 minutes?
The moment you receive the sample and within preparation time should not be more than 90 minutes. It is not that within collection of the sample and insemination, the ideal time is 90 minutes. If it takes more, the results of IUI will go down.
Okay. Again, this from Dr. Saumitagya Banu. If elderly mother, if ovulation occurs on the day 10 or day 11, can we proceed IUI? CIUI, I don't know if it's the right term.
Yes.
Spelling mistakes.
Yes.
Okay. Again, from Bimal Gupta, if the semen quantity is less than 0.5 ml, can IUI perform?
Yes.
Okay. From Angelica Almeida, I think she's from Kenya, if I'm right or I don't know. Does the post-wash insemination volume matter?
If you have more than 0.5 ml, then usually the sample is diluted, and plus there is backflow of the sample.
Okay. Next question from Dr. Saumitagya Vanu. How to achieve follicle synchronization?
Use OC pills in the previous cycle.
Okay. From Dr. Sadhna, it seems. Hi, ma'am. Can we do IUI with Tesha sperm in case of obstructive AGU? I don't know.
No, you can never do that because the total motile sperm counts required are more than 3 million minimum or 5 million for a good result. So with TISA, you can never get that amount.
Okay.
TISA is only meant for ICSI, not even IVF.
Okay, the next question again from Vabhya. Each lens hook recommend in a sperm selection for IUI process?
లాస్ట్ టైం కూడా నమస్తే లాస్ట్ టైం కూడా వామిటింగ్స్ అని చెప్పినావు టాబ్లెట్స్ ఇచ్చినాం కదా అప్పుడు మొన్న ఇంటికి వెళ్ళినప్పుడు కూడా అయినాయా?
Kindly mute the.
Let
Please
me
put.
Okay, fine.
Hmm.
Is Lensuk recommend in a sperm selection for IUI process?
I really don't know what is Lensuk.
Okay, Bhavya, you should clear the question. Okay, if 2-3 dominant follicles are there, then after also HCG given and IUI done.
Yeah, not more than, if this follicle number is more than 3, it should not be done because there's a multi pregnancy chance. And but one thing is, you can always take the consent of the patient and go ahead and do the IUI, then go ahead with a fetal reduction.
Okay. If 2-3 dominant follicles are there, then after also HCG given and IUI done.
What is the question?
DP, I don't know who is DP. They have mentioned the name. So please clear a question. So we will be answer here. Now, Dr. Sheila, what is the minimum amount of post-wash sample size required for insemination?
0.5 ml, and the count should be total motile count more than 5 million.
Okay. DP has same question again, but I think you have to elaborate the question so Dr. Sonam can answer. Okay. Can we advise PT to have natural intercourse on the day of IUI patients? Okay.
Yeah, you can.
Okay. So this can be after the IUI or before the IUI?
I just said you will allow intercourse on the day of HCG. On the day of IUI, post next day, you can advise them for an.
OJA. Okay. Okay. Uh, can we, yeah. What is the protocol and dose of estradiol in this endometrium?
Poor endometrium. Okay, you can have estrogen gel to the tune of 1 spatula TDS for 3 days. Or if you want to give to higher dose, you can have 4 spatula BD for 1 day also. That also, if there is no endometritis and it's because of the hormonal thing, the size is less, it will increase.
Okay. The next question is what is the protocol and dose of? Okay, the same question. Dr. Supriya, progesterone hike on day 2, how to reduce?
I just answered. It's you have to suppress the cycles. You can do it with long-acting Lupride also, or you can do with OC pill, but you'll have to wait for a cycle.
Okay. Again from Dr. Sadhana, what is the maximum day of cycle where we can do IUI like in PCOS patient where we have slow follicle growth?
You just have to have the mature follicle and the endometrial thickness, and the hormones should be normal. There should no be, and post LH surge, you can do it.
Okay.
But
The
at the
next,
most, this time is around 21 days, because if the cycle stretches beyond 21 days, it's better to drop the cycle.
okay. The next question is, what is the maximum day of cycle where we can do IUI like in PCOS patients where we have slow follicle growth?
This is what I'm trying to tell you. With PCOS stimulation, the patient should be prepared mentally for a longer cycle. Usually the patient will have follicular growth within 20-21 days. But if it takes beyond that, the results are poorer.
Okay. The next question from Dr. Sheila. If air is inseminated with sample, will it reduce the success?
There is a contradictory view about both of them. Some people advise and some people do not advise. You do not need to introduce the air into the cavity You just have to introduce air into the catheter, so the whole catheter is empty when you introduce the sample. Minimal in microliters, if air goes inside the uterus, it does not affect the result. Because
Okay.
the speed of the insemination has to be very slow.
Okay. From Dr. Norin, follicle is mature, trigger is given, but endometrial free fluid is there in the cavity. How to proceed?
If the endometrial fluid is more than 35 mm, the results are not achieved. If it is less than 35 mm, you may try with ideally to the endometrial fluid. What I follow is I always examine the endometrial fluid, but the recent conference I attended, they said it's better to aspirate if it is less than 35 mm fluid and go ahead with the procedure.
Okay. Disha, how much volume of sample is loaded in IUI catheter?
0.5 ml.
Okay. From Dr. Sadhna, when to give gonadotropins and dose of gonadotropin in dense PCOS where no follicle growth on the day 10 or day 11?
It will depend upon her LH-FSH levels, one thing, and for IUI, we just need 1 or 2 follicles. So low dose like 37.5 mg of HMG can be done, and it can be gradually increased, and then gradually increased to 75, but not more than 75.
Okay. The next question is, if patient developed 8 to 10 follicles with letrozole, how to proceed next cycle?
The dose of letrozole has to be halved. And usually patient will never develop 8 to 10 cycles. What dose have you used for letrozole that she developed 8 to 10 follicles? Letrozole usually gives only 1 or 2 follicles max when given in the dose of IUI.
Okay, okay. The next question is, how long the insemination time minimum taken, how much slowly?
30 to 60 seconds.
Okay. From PM Sinde, can we put both the couple on coenzyme plus antioxidant combination to improve sperm quality and ovulation induction?
Yes,
Is it
yes,
helpful in IUI procedure outcome?
yes.
Okay. Again from Bimal Gupta, ma'am, semen quantity is less than 0.5 ml. Which method we should use for washing? And yeah,
Swim up.
okay,
Simple wash and swim up.
okay. Again from Bhavya, can the washing media add to the sample and make it 1 ml or double collection of a sperm sample in a single day based on count?
Yes, you can do that if the patient is because the sample volume varies according to number of ejaculates. Some patients will increase and some will decrease. But usually if the sample, because all these patients, when you take up for IUI, you have already done a semen examination for them. If the sample is less, you need out to find out what is the cause of less amount of sample, what is the pH of the sample. These all parameters, when taken into consideration and treated, you will have sufficient sample also.
Okay. From Dr.
You can
Supriya,
dilute the sample. The question was, you can dilute the sample. Yes, you can dilute the sample. But end result should be the total motile sperm count should be more than 5 or 10.
okay. From Dr. Supriya, semen volume 2 ml, then double density 2 ample of IUI done or not?
Semen volume is
2 ml, then double density 2 ampoules of IUI done or not?
Question is not clear actually. If it
Dr.
is like
Supriya,
double density gradient can be used with 2 ml of semen, yes, it can be used.
okay. Again, the next question from mobile, I don't know the name. Which centrifuge is used for a sperm washing?
Subhag.
Okay, I think I should answer this question. Yeah, So there is a andro-was sperm washing centrifugation machine. So you can use that machine for a sperm washing. Okay. The next question from Dr. Sadhna, it seems. Can we use injection HMG and letrozole in same cycle?
Yes.
Okay. From Bimal Gupta, if patient has history of miscarriage, then what is the success rate of IUI? How can we provoke this incident?
First, we need to find out, you're talking about what kind of miscarriage are you talking about? How many weeks? And IUI as such, the only indication for IUI can be that there may be some immunological factors, but that leads to infertility and not to miscarriage. There has to be some other points for miscarriage. So chromosomal analysis of the husband has to be done, the wife has to be done, then the uterus has to be seen, the tubes have to be seen. So these are the reasons for miscarriage. You need to find out what is the reason for miscarriage. As such, IUI will not improve the reduce the incidence of miscarriage unless you change the sperm, like you use a donor for that.
Okay. The next question is Dr. Srisa Krishnan. Double density was which machine? I think this question already answered. That's andro was sperm washing centrifugation. So that you can use this for sperm washing. This is a double density medium. Yeah. From DISA, if swimmer process sample contain pellet in IUI catheter, then is it hamper result or anything?
Yes, definitely.
Okay. Dr. MK, can we use HMG and letrozole in same cycle?
Yes.
Okay. I think Dr. Supriya has asked the question, so she added the thing. Semen volume 2 ml, then double density 2 ml of IUI done or not? And then she added 2 sample. Okay, I think question you need to put all here. Okay. The next question is from Dr. Sadhna. Role of elagolix when the follicles are 18 to 20 mm, but thickness is less than 6 mm. For the adjuvants like ecosprin in sildenafil to act.
It will depend what I don't think so there's any role of elagolix, one thing. Then other thing is adjuvants do help. And the third thing is, if you have used clomiphene citrate, you will have to wait a longer, because the size of the follicle has to be bigger than 22 mm, so that the endometrium can catch up. Or you use letrozole in the next cycle, or you use HMG in the along with the CC. Then only you'll get a thick endometrium. If all these don't work, then you have to look for the physical factors, like there may be endometritis, or there may be some mild Asherman may be there, or you will have to do an hysteroscopy or hysteroscopic PRB, because thin endometriums are tough to treat.
Okay. The next question is, do we always confirm ovulation and then do I or do at around 40 hours after trigger? Dr. Sheila.
The results are always better if ovulation is documented.
Okay. From Disha, when we do repeat IUI on consecutive next day, what happened?
If done properly, one single IUI is more, the results are equal.
Okay. What the ideal time gap between the IUI cycle? Bimal Gupta.
If the ovary is silent, the next cycle you can take up for another cycle.
Okay. From Dr. Supriya, if follicle is 14 mm but ET is 6 mm, can we add tab pro gynova or not? How to treat the poor vascularity on day 20?
Poor vascularity on day 20.
Yeah.
Day 20. Oh, you day 20 is your pre-IUI, post-IUI. And what kind, whose vascularity do you want to increase, the endometrium or the follicle?
Chandan, can we allow the participants to speak because
Yes,
text
yes. If
questions are
they
not
want,
very.
yes, yes, yes. So if
Yeah, so
you are,
go on.
let
Chandan.
me, yeah. So please let me know if you want to speak. I can just raise your hand in your system that I will get notification and I will allow you to unmute yourself.
Yeah, I
Okay.
think that will be a better
Yes,
discussion
yes,
because
yes.
many questions are not clear.
Okay,
So
from
unless the questions are clear,
okay,
the answer
okay.
cannot be.
So Raga is here. So I will asking to, yeah, you can ask Raga. You are now unmute yourself.
Yeah, good afternoon, ma'am.
Good afternoon, Raga.
Ma'am, can we go for clomiphene citrate in ovulatory cycles to get at least 2 to 3 follicles to
Yes.
improve IUI success? Ma'am?
Yes, you can get.
Also, ma'am, is there any correlation between single follicle versus at least 2 to 3 follicles for IUI success?
Definitely. 2 to 3 will give you better cycle result.
Last question, ma'am. Ma'am, how to improve ovarian follicle vascularity? Sometimes even the follicle is 17 to 18 mm, the vascularity is very poor, ma'am.
Increase the time.
Okay. Thank you, ma'am.
Usually, poor vascularity will occur in your patients of these CC patients.
Okay, okay. Does it hinder the IUI success, ma'am? For vascular
Yes,
ovarian follicle?
yes.
Okay. Okay, ma'am. Thank you so much.
Welcome.
Thank you, Dr. Raga. The next is Dr. Supriya.
Madam, good afternoon.
Good afternoon.
Madam, I have a doubt that suppose the uterine artery PI is less than 3. So does it affect for a IUI cycle?
Yes.
And second thing, if the during ovulation induction, if the ovarian follicle is like 16, 17, and it is just 5 to 6 mm and poor vascularity, so can we add tablet Proginova in that so that to get a ET goods?
It's better to add the gel or hemihydrate tablets.
Vaginally?
Vaginal. Yes.
Semi-hydrate? Okay.
Yes.
And another thing is, double density gradient method. I want to ask if the Semen sample, suppose 2 ml. And if you're
Okay.
using 80%, 40% double density media, and along with that 1 ml sample in one tube, and other sample we put 1 ml. So that we can do 2 samples and then collective procedure we can do it.
It will depend upon your counts. As such, is not going to affect you.
The count is okay, volume
But
is
why
2
do you
ml.
want to do this?
Madam, I want to do in patient with the like 1 ml sample is okay na for one tube. I'm talking about 40%, 80% they have 1 ml and with the 1 ml semen sample. Or should we use 2 ml both? Means 2 ml we have to use
I
or 1
understand
ml.
what you're trying. I'm just trying to ask you, why do you want to separate the sample into 2 times? Matlab, 2 different tubes.
Suppose sperm yield is low or the volume count is less, then can we use, or is there any rule?
I don't think so.
Then you can use in single tube only 2 ml sample. Is it okay?
Exactly. Yes. The question should be, if the sample is around 7 ml, then what to be done?
Okay.
ठीक है ना?
Right.
If the
And in
sample,
fact, yeah.
if the
I
7,
would like to add some
Okay.
point. Yeah, sorry,
Okay.
Dr. Sonam. Yeah.
Mhm.
So the researches on this sperm washing shows or has proven that if we are going ahead with double density, where we are using 1 ml low density, 1 ml high density, then we can overlay 2 ml up to 2 ml of semen sample. So that gives you a good result. So no need to split it, because unnecessary that will increase your consumable cost, overall cost of the process. So unless, as Dr. Sonam is mentioning, if the volume is too high, then you don't need to split. 2 ml is good enough. So you can manage that in single tube.
If the volume is too high, then you need to centrifuge the sample, concentrate the sample, and then overlay.
Okay, ma'am. Thank you, ma'am.
Welcome.
So any other question, you can just raise your hand if you want to ask. We will be having a question here. Sohan, can you, Subhajit, can you share your window, and you can speak about that how Androvas is here to help them.
Sure. So there are one question in our chat box. Okay.
Yeah, let's
Just
address
like
the question first, and then
yes,
you
yes.
guys can talk about that.
Chandra sir, please allow my video.
Okay, I think you are allowed.
Okay, but it's showing that admin have stopped it.
Okay.
Okay. So let's.
Yes, you can do that now.
Okay. Thank you. So there are one question from Dr. Rithi Singh. She's asking, are they going to give estrogen gel? Question to ma'am you.
Pardon?
Are they going to give estrogen gel?
You can give it from the day 2 itself.
Okay, great. We would like to have many more questions. If you have, definitely you can raise your hand, and you can ask on Q&A section, also on chat section. We definitely love to give answer on those all questions. Okay, so just in short introduction, my name is Shubhajit Mondal. I'm a general manager in Supak Health Tech. I would like to take a few minutes to describe about the Andro wash. So in one line, Androwash is an automatic sperm washing solution. Okay, so we have 4 claim. It's a skill-less process. Okay, it's a very simple, very easy, and it's very accurate. It's take less time as compared to the conventional technique.
Chandan sir, your screen, my screen is being shared. Your screen is not being shared.
Okay. Let me share the screen. I think one question from, I think name is Zoom user written here. So please ask your question.
Hello, ma'am. Good afternoon, ma'am. Ma'am, when do we consider the endometrium to be thin in proportion to the follicle size, ma'am? Suppose if the 12 follicle is seen, and if we see a endometrium of only 4 to 5 is it called thin endometrium? That synchrony?
No. The synchrony of endometrium and follicle size is important, because a mature follicle usually will give us a mature endometrium.
Yes, ma'am. But how do we anticipate earlier? Like at the when do we know it is?
You must have been following the cycle beforehand also.
Yes, ma'am. When I saw a follicle size of 18 I saw it as 5.6 and I was like, I started estrobet at that point of time. Then I had this tension of premature, means this will rupture, right, ma'am, if I wait for the endometrium to thicken. So what do I do?
No. It depends. It's a natural cycle.
Stimulated cycle, ma'am.
What did you stimulate with?
Letrozole and gonadotropins, 1 dose of HMG.
Okay. So if the cycle, and what was the result in the natural cycle?
Natural cycle, ma'am, it was not with me, it was with someone else actually. So
and what was the endometrium there?
It was not tracked properly, ma'am. I'm not aware of the previous reports so well.
The most important thing to treat your patient properly is to know your patient properly.
Okay, ma'am.
Fine. अगर 14 mm के बाद भी अगर आपकी endometrium 6 mm से कम जा रही है,
okay,
तो might as well start the gel.
Okay, 14 and if it's less than 6, I have to.
Yeah.
Okay, ma'am. Thank you, ma'am.
So another question here also, ma'am, in chat box. Okay, can we briefly explain about IUI catheter adjustment of length according length of uterocervical canal from Dr. Samatha?
The uterocervical length, you have to just pass on the cross the internal os and around a half a centimeter beyond it, because you don't have to touch the fundus of the uterus. You don't have to touch the endometrium at any level. You just have to enter, inject, and come out. Assessing the length will depend upon the ultrasound length of the uterocervical length of the patient. And if you have an ultrasound guided IUI, it is always better.
Okay, Subhajit, go ahead. I think we don't have any question as of now. Okay, wait. One question is here. Okay.
Mr. Chandan, I would like to tell you one thing. We'll take questions after the video.
After the?
After this presentation of the video of the andro wash.
Okay. Okay.
Okay. Should I start?
Yeah.
Yeah.
Okay.
John, get that. Yeah, mask.
Okay. So I was saying that about andro wash. So normally, so challenges in the conventional technique. Okay. So normally, so there are three different types of sperm washing as we know. So one is simple wash, swim up, and density gradient. So most of the times for IUI and for IVF, a density gradient technique is mostly recommended based on few things. Okay, and one of the reason we get quantity of palette is always higher as compared to the simple wash or swim up technique, and simple wash is not recommended because of some other reason also. So andro wash is also dedicated to the density gradient technique. So doing a density gradient technique, it's a very skilled based work, but if you have andro wash, then you don't need much skill. It's very simple. Okay, it's a patented technology. It's very simple, and it's very accurate, and as well as it's very easy to do. So normally in the conventional technique, it's take little bit more time, but if you do with andro wash, it will take after liquefaction only 16 to 18 minutes, including layering, including centrifugation, including discarding. So in the conventional process, so there we are using actually conical tube. So conical tube is actually not designed for blood and urine processing. Actually, it's designed for, sorry, it's not designed for sperm washing. It's actually designed for blood and urine processing. But actually, we don't had any option in the market. So that's why we are using this tube. But now we have a option. Now we have a patented tube called a smart tube, which is actually, if Chandan sir, you can show it from your skin, it will be best about the smart tube. So this is a patented tube. Okay, so at this moment I don't have the tube, so I can explain what's the benefits from conventional tube to the smart tube. Okay, so in the density gradient technique, we have three steps. First is the layering, second is the centrifugation, third is the discarding. So in the layering itself is a time consuming process, as well as it's have so much human error. So sometimes we face challenges to do the accurate layering, but by help of smart tube, this layering can be done automatically without any skill or without spending much time and without having any human error. It's very distinct layer ban jata hai. So then after the centrifugation, so in the centrifugation, we sometimes we say that 1500 rpm is the best, sometimes we say 2200 rpm is the best, sometimes we say 20,000 rpm, sorry, 2000 rpm is the best. But actually we do semen preparation by help of RCF, which is relative centrifugal force. And a relative centrifugal force in like that, so means how much force we will apply, it will decide how much motile sperm quantity we will get. So if force is too much, then what will happen, more live sperm will be damaged, and if force is less, so then what will happen, we will not get the equal quantity of motile sperm which is actually desired to get. So we have to have a middle force which can give us the best result with less damages. So our R&D team do that R&D. So what RCF give the best result, they find it, they inbuilt that RCF with software in our andro wash. So it's automatic. You just don't need to set up anything for each time. So best RCF is inbuilt. You just need to press one button, it will run automatically, it will stop automatically, it will give the alarm sound. So first layering is my automatic through help of a smart tube, then my andro wash is also automatic, and then my discarding. So in the conventional technique, discarding is a very challenging job, and during discarding we may face so many human errors. So human errors like that, first normally we do discarding help of pipette. So it's possible that we can release some bubbles during discarding, so that bubble can become free radicals. It can damage the live sperm. Also, by help of pipette, we cannot discard 100% supernatant from the tube. And if we are not able to discard 100% supernatant, then what will happen? That dead sperm, that supernatant have dead sperm, that dead sperm will release after a certain point of time ROS, reactive oxygen species, and then ROS will damage the live sperm. Okay. And also that sometimes it's possible that we can, during discarding drop by drop, we may remove some part of pellets also when we are pipetting from the tube. So there are several challenges, several human errors in the conventional technique. Okay, so we have the smart tube, that is the patented, so you don't need to do pipette in, pipette out and all. You just need to tilt the tube. Okay, all supernatant will be discarded automatically, and only live sperm will be holded at the bottom, and it will be vacuumed. When you will tilt the tube, only supernatant will be came out, not the pellet. Okay, that's the technology. So my layering is automatic now. My andro wash is automatic. Also, my discarding also automatic. So that's why we, if so that if in certain time or in a particular day, if a skilled technician is absent or anything happen, so anyone can able to take care. And even it's very simple to do, very easy, and it's very accurate. So first, it save times, it's also save human errors, and because of this all reason, it's give more motile sperm as compared to the conventional technique. So let me mention one third-party validation. Okay, so it's by LifeCell Chennai Lab, which is largest sperm bank in our country. So after we got featured in Shark Tank season 2, so they take andro wash and they did one R&D. So they take one sample, split into two. One part they wash with andro wash, another part they wash with their conventional technique, with their technician. So I think they did 37 number of total wash. Each time they analysis with CASA, computer assisted semen analyzer, and they average all the data, and they find it through andro wash. They got 21.4% more motile sperm as compared to the conventional technique. And we have also internal research paper which is already published in the international journals. Even this validation, this internal research paper, you can easily find it from internet. And if you would like to see that, you can message on our WhatsApp 9036 490 490. Again, I'm repeating, this is our official WhatsApp number, and you can call on this number also, 9036 490 490. Okay, we can share all the details. And if you like to have the virtual demonstration or physical demonstration, if you take virtual demonstration, you can book a slot. It will take only 10 to 15 minutes. You can book a slot on your own convenient time, and you can someone from our R&D team will give the demonstration. Okay, it will not take more than 15 minutes. It is almost 15 minutes. Okay, so you can reach out to us for demonstration. You can reach out for the research paper. You can reach out for if you want to know more about andro wash. We'd definitely like to help you with that. Thank you so much.
Thank you, Subhajit, for explaining.
Please continue.
So research paper I have already shared in the chat box. Another webinar topic that we want to cover in upcoming webinar. So I have given one survey. So please fill that survey question so that we will cover. So the question is here: setting up a profitable IUI clinic within your existing practice, live sperm washing training, common reason for IUI failure and how to address them. And the fourth one is the modern management of PCOS related infertility. So please fill those surveys, so that will help which webinar you want to do. So just let me know. One question is from Dr. Simran Kaur, ma'am. You can answer. In follicular phase, need to give estrogen gel the whole cycle?
Chandan sir, can you repeat that question?
Only in follicular phase need to give estrogen gel in the whole cycle.
No.
Okay, Dr. Simran Kaun's answer. Okay, if you have any questions to be answered, just let us know. We will be happy to answer your query. If you have already have given survey, only 16 people have filled this survey. So please feel free to fill this survey. So we will plan the next Sunday again or Saturday, the again upcoming webinar on these topics. We will cover it. So
And
please,
another side, if you have any question related to ERT registration, ERT or sperm washing, IUI, you can ask any kinds of question. We'd like to answer that.
okay, Bimal Gupta, you want to ask one question? Okay, yeah, you can ask. You can unmute yourself and ask.
Ma'am, yesterday when I was in during a call, one doctor asked me that इंसर्मिनेशन जो है वो फंडस में मतलब लोअर साइड पे होना चाहिए, अपर साइड में या सर्विक्स रीजन पे?
Fundus से थोड़ा सा नीचे around just at the level of tubal ostia, मतलब it will come out to around 0.1 centimeter below the fundus.
Okay, ma'am. Thank you.
Dr. Wala Lata, could you please share your number that you have asked? If you have any question, feel free to ask or raise your hand. So we will be happy to answer. So people are more concerned about to know live sperm washing training that we will do, modern management of PCOS related infertility. They also want to know. They also want to know common reason for IUI failure and how to address them, and setting up a profitable IUI clinic within your existing practice. Okay, I'm ending this survey. Okay. Let me know if you have any question. You can unmute yourself, ask or raise. Otherwise, we will conclude this webinar. Okay, I think we don't have any new questions from the. Okay, so someone has raised a hand. Let me check who is the. Okay, Bimal Gupta. Yes, you can ask Bimal ji.
Sir, I have already asked my question.
Okay, okay. Thank you. No questions. Okay.
So if no more questions, then we can conclude the session.
Yeah.
Thank you to everyone, all the participants. Thank you so much, Dr. Sonam ma'am, for guiding all the participants, all the gynecologists and infertility practitioners in IUI protocols and tips. And we hope we'll have more insightful sessions in the upcoming weeks. Thank you so much, ma'am.
Thank you, Sohan. Thank you, Subhaji. Thank you, everyone, to joining this webinar.
Thank you, everyone.
Thank you so much, everyone. Happy Sunday.
Yeah.
Happy Sunday.
Yeah.